at the Royal Free Hospital, and I also lead rare intestinal as a national centre here as well for rare intestinal cancers and a research programme across University College London. Tonight is the first of 3 healthcare panels organised by Kinloss Synagogue in partnership with the Wellington Hospital and United Synagogue. And I was given the privilege of chairing this series. So there's going to be 3 series of lectures. The first one tonight on healthcare problems for children during the pandemic. On the 2nd of March, we'll have a panel on the latest thinking and medical advances in adult medicine. And on the 13th of April, there'll be a panel about optimizing your health for the over 70s. The format for tonight will be that each panelist will give a 3-minute or so overview about COVID-19 and their specialty. So we have Dr. Lisa Anderson, General Practitioner, Dr. Lee Neumar, Consultant Paediatrician and Allergy Expert, Mr. Andy Goldberg, Consultant Orthopaedic Surgeon, and Dr. Mark Furman, Consultant Gastroenterologist. And I've also received in advance some questions from audience that have been sent in. But please, during the evening, use the chat box at the bottom right of your screen usually, and send in and type in your question. After the panelists have each given their individual response to my opening question, then once we've been through all the panelists' short answers, after that we're going to open it up into a full panel debate and discussion and go through your questions. So without further ado, we will start off in general practice with Dr. Lisa Anderson. Lisa is a very experienced GP who until last summer had been a partner for 27 years in the NHS practice in Hampstead Garden suburb. Many of you will know it well. She now practices full-time at the Wellington Hospital in St. John's Wood as a private GP. She holds a diploma in paediatrics, obstetrics, gynecology, and is a member of the Royal College of General Practitioners. And within her general practice, her specialist interests include pediatrics, women's health, mental health, and health screening. She also specializes in corporate clients and provides GP services to staff and corporate companies. Lisa is a member of the Medical Advisory Committee at the Wellington Hospital. So welcome, Lisa. So let's see, what is your feeling about and what's the impact been of COVID-19 on your practice? Over to you, Lisa.
Okay, thank you. Firstly, Martyn, thank you for that lovely introduction, and it's an absolute honour to be part of this panel this evening. So, general practice, as we all know, is a very wide topic, but overnight we've gone from face-to-face consultations to having to assess remotely, whether it's on the telephone or via video. And in the adult patient, that's a lot easier because the adults can usually speak for themselves, but children cannot always communicate with us. So we've had to develop tools to involve you as parents to help us and assess your child remotely, to help us, helping you to recognise signs and symptoms that would determine when you need to seek medical advice. So, for example, checking your child's temperature, their state of hydration or dehydration, their degree of wakefulness or drowsiness, how long the fever's been present, whether they're passing urine, whether they have diarrhea or vomiting, and whether the fever is coming down with paracetamol or ibuprofen, as long as your child can take ibuprofen. So how can we help you? So the Royal College of Paediatrics and Child Health has developed a series of very useful posters that you can download from their website. And it's based on a traffic light system of red, amber, green, where red is where you need to dial 999 or go to accident and emergency, amber where you need to call us or dial 111, and green where we would be happy in conjunction to talking to you, leaving your child for assessment at home. As I said, these posters are readily available on the website, and they are divided into 3 groups. So there's one specifically for children under 3 months, and that is invaluable because we're in winter and we have respiratory illnesses at the moment, apart from COVID. And this looks at your child's respiratory rate and other issues, and it's all very nicely tabulated on these charts. The second one is for children and parents of all ages. And then there's a third one that is applicable to young people. And I strongly encourage you to look at these, download them, have them by your side. It is not a substitute for calling your GP or 111, and I cannot emphasize that enough. The other thing that we found is people not wanting to go to A&E. And I just want to reinforce that there are safe areas, and the likelihood of your child becoming seriously unwell from COVID is remote. We know that very few children are seriously ill. And if your child does need emergency treatment, you should go to A&E. The other thing that has obviously been impacted is childhood immunisations. And I just want to reinforce really that we should carry on with that. I think, Martyn, I'm going to stop there. I know we have a question on mental health, which I'm going to tackle later.
Yes, thanks very much for that, Lisa. And then we're going to get questions from our audience, and then I'll come back to you as well. I'm going to move on to Dr. Lee Neumar. And Lee is, he trained at University College London, Middlesex Medical School. He's got a BSc in immunology and cellular pathology, a master's in pediatrics. He did his postgraduate training in general pediatrics and pediatric allergy, working at the Great Ormond Street Hospital and St Mary's Hospital. And as a consultant now at the Royal London Hospital, he set up a new tertiary pediatric allergy service some 10 years ago for East London. He's been a board member of the British Society for Allergy and Clinical Immunology, editor of their magazine, and he has particular interest in acute allergic reactions, anaphylaxis, and molecular. Now, same question to you, Lee. What's the impact of COVID-19 on your pediatric and allergy practice? And then we might just open it up a little bit broader after that, just to give us a little summary about what you find exciting in your field generally. But first of all, COVID-19 and the impact on your practice.
Thank you very much, Martyn. Thank you for the introduction. I think the biggest impact that we've seen for the moment is the difficulty in conducting appropriate consultations remotely. Like Lisa said, we have to do most of it without being able to see patients face to face. So we try to assess patients over the telephone or over video link, and especially when looking at children's rashes over video, it's extremely difficult. So we ask people to send photos in beforehand. I think we're trying to minimize contact as much as possible to see us in person, and that has really affected the way we offer our treatments. Immunotherapy is something that we'd like to do by injection, but because of the routes, the patients have to attend hospital around 4 times week on week, and we've therefore tried to convert them to oral immunotherapy instead, which can have a major impact, as not all patients respond as well to oral as to injection, although it can be successful equally. The other big issue that we've had is trying to do food challenges on patients in pediatric allergy, where we try to introduce new foods into their diet to try to open up their diets in order to allow them to have a broader range of foods that they can eat. And because of the nature of the challenge, it involves coming into hospital, having to spend around half a day there, and therefore we're trying to do as many as we can at home. Clearly, these challenges can be high risk, i.e. they can cause anaphylaxis, and therefore we have to judge carefully which ones are feasible to do at home and which ones still have to be done in hospital, and choose carefully which patients can still come in, bearing in mind the concern that we have to keep patients away from hospital as much as possible, unless, of course, there is an emergency. I think moving on to your second point about advances in pediatric allergy specifically, I think the two really important points, really important areas where there has been impact on many people are the ability and definite option of trying to prevent allergies from occurring in the first place. And we try and encourage patients, if possible, to introduce food into their diet from an earlier age than previously thought. So there is a lot of evidence initially starting from the LEAP study, which was based at St Thomas's Hospital and published several years ago now, showing that early introduction of peanut into a baby's diet as from the age of 4 months, possibly earlier, can decrease the risk of peanut allergy by 86%. And therefore, if a child is at risk of increased allergies and it is safe to do so, then we try to encourage them to introduce peanut into their diet. Egg is another food which is often found to be helpful to introduce early and prevent the onset of egg allergy. And there are also other studies showing that more foods, if introduced very early, even in some hands from the age of 3 months, can possibly help decrease the risk of long-term food allergy, where cure is much more difficult than other forms. Just briefly touching on immunotherapy. So we've been doing immunotherapy for a long time for pollen immunotherapy, dust mite immunotherapy, but more and more there are now options to do immunotherapy for foods, probably most famously peanuts, and there are a number of studies still ongoing worldwide looking at this. There is a lot more going on in the United States at the moment, but in the UK it's starting to come through, as well as for other foods like milk and egg. And I think that's a very exciting potential area where allergy can potentially be cured in the nearer sense, rather than watching and waiting and preventing.
Thank you very much, Lee. I believe there's a bit of a lag on my video, and if that's a problem, I may switch it off during the meeting. We'll come back to you a little bit later on with questions in the panel discussion. We're going to move on to Mr. Andrew Goldberg. Andy is a fellowship-trained orthopedic surgeon who specializes in ankle and foot disorders for adults and children. He's the lead foot and ankle surgery at the Wellington Hospital. He qualified from St Mary's Hospital in London and underwent orthopedic training, followed by specialist fellowships in Oxford, Europe, and the United States, before settling as an orthopedic surgeon at the Royal National Orthopaedic Hospital. And he's also, in fact, an honorary associate professor at University College London. He runs a pioneering multi-million-pound research program involving stem cell research, clinical trials, and he runs new innovations in healthcare programs as well. He's been chief investigator in NHS-funded National Institute of Health Research, Health Technology Assessment Studies for surgical treatment. He lectures internationally and is a well-published author and editor-in-chief of several best-selling books. His work has been cited more than 2,500 times, so he needs to get it right, otherwise 2,500 people or more are getting it wrong. He sits on several national and international committees, and in 2011, he was awarded an OBE by the Queen for his services in medicine and surgery. So, Andrew, great pleasure to have you. And I think actually the introduction is longer than your 3 minutes than that we've allotted. But just to give your overview of the impact of COVID-19 on your orthopedic practice, and maybe if you had a chance as well, some of the exciting developments in your field.
Thank you very much, and that introduction was thoroughly undeserved. So, again, like Lisa said, I'm very honoured to be on this very innovative, forward-thinking meeting organised by Kinloss. After all, it's all about patient to patient, which is the future really of medicine. Physician to patient, shall I say? So it's the future of medicine. Orthopaedics is like every specialty has been affected, and orthopedics is broken down into trauma and orthopedics. And most of the work is elective, but trauma clearly had to carry on because that's an emergency work. And weirdly enough, the trauma actually decreased during the pandemic. And that's perhaps as a result of people not going out and not injuring themselves as much. But more so and more worrying, it's also because people stayed away from hospital, being scared that they didn't want to go into hospital. So a lot of injuries that should have been seen and treated, and it was safe to do so, were being withheld, and we then saw a storm of them coming over the summer, and we're likely to see a storm after this current lockdown. The elective, however, came to a standstill, and so that means that there are now many, many tens of thousands of people that are waiting a hip and a knee replacement that haven't got it, and are going to be sitting on waiting lists, and sadly that does potentially mean that we're going to go back to the situation we had in the 1980s with long waiting lists. Also, the lockdowns had an effect on our patients, as already been alluded to, in terms of its mental health impact. I've personally seen both to my own kids and lots of patients where children and adolescents are converting 5 hours of football and running into 5 hours of Fortnite and computer games. And this has a knock-on effect. It makes them become deconditioned and have weaker bones, and that's obviously not a good outcome. There have been positives from the pandemic. So there was a partnership between the NHS and the private industry. And the Portland Hospital, for example, delivered 200 NHS babies and thousands of NHS urgent surgeries, such as spine surgery and cleft palate. We all, like Lee alluded to, became experts in technology, using Zoom this and Zoom that. And that was a rapid, even for the laggards like myself. And we all changed the way we work. So we all became junior doctors, the consultants became junior doctors and nurses, and even Deliveroo drivers. And that's been a fundamental change. I thought I'd show you a photograph of some of the things that we do. And this is sort of an indication of the world that we're living in at the moment, and how that's me in theatre. So it's been a changing paradigm. Thank you.
And we'll come back to you a little bit later on the panel. And then finally, we're moving to Dr. Mark Furman. Mark is pediatric gastroenterologist and clinical lead at the Center of Pediatric Gastroenterology at the Royal Free Hospital, which has one of the biggest inflammatory bowel disease services in the country. And during COVID restructuring, that service is partially relocated to Great Ormond Street Hospital. He also runs clinics within the Portland Hospital and Golders Green. His other areas of interest and research are celiac disease and eosinophilic esophagitis, and he's on British and European committees for these. He's worked with NHS England to develop and publish national clinical standards and pathways for pediatric gastroenterology in the UK. In 2018, he was appointed Chief Medical Information Officer at the Royal Free London, with special interest in digital transformation in healthcare. Mark qualified from University of Cape Town and is a fellow of the Royal College of Paediatrics. So Mark, thanks very much. Same question to you, the impact of COVID-19 on your gastroenterology practice, and if you have time, just to make some comments on exciting developments generally in pediatric gastroenterology. You can unmute yourself as well.
Thank you. Thank you, Martyn, for inviting me, and for HCA and Kinloss for having us. And hello to everybody in the audience. I'm going to try and not repeat what others have said, because I think we've all had quite similar experiences in terms of being thrown into uncharted territory quite suddenly with the onset of COVID and into remote working. The one thing that I suppose I did have up my sleeve, if you like, was the fact that I've been working on video consultations as part of a project to implement in January last year anyway. We didn't quite expect to roll it out at the same rate as we needed to, because we needed an incredible amount of bandwidth to implement it. But I've got used to wearing these in consultations now, and we've all got comfortable in doing video consultations. But I think along with that, I've also kept on reminding myself, my colleagues, that you don't want to get too comfortable, and it's about what you're missing. It's about what you're not seeing with not examining. And I think it came to a head when I had a patient who came to see me with constipation, and had this been a video consultation, I probably would have managed the constipation according to the history. But when I examined the young person, they had self-harm marks all over their abdomen, and the conversation and the plan suddenly took on a very, very different type of planning. And it made me realize what we are missing out on when we are doing our video consultations, and how important the face-to-face contact is. And I relish the time where that all returns back to normal. I think there will be some stages where we'll be able to do video consultations, but really the people contact is so crucial to all that we do, particularly in pediatrics. I think the other thing which struck me was how we so focused on our patients. All of us are always focused on our patients, and suddenly we had to think about ourselves. We had to think about our own risks, our own vulnerability in dealing with people coming through our clinics potentially with COVID. And it was the first time that I thought of my health alongside my patients, where we always are so patient focused normally. We also get taken out of our comfort zone because we have all of our processes, all of our pathways that are in place that work for us and our patients, and suddenly we have to do things differently. And that introduced a huge amount of risk, and it's about mitigating for that risk, which I found challenging and also exciting. We developed ways to have joint decision making. We, like Andy, lost our access to theatre and endoscopy, so suddenly we've got hundreds of children waiting for endoscopies because you could only scope the most urgent, and having to manage that risk alone is much greater risk than managing it as a team. And I think that's where teamwork really came to fruition, where we had to pull together and discuss each patient together to make the best and safest decisions. Environmental change. We had to suddenly go into another hospital where where nothing was familiar. So scoping at Great Ormond Street, using Great Ormond Street facilities. They've been most welcoming to us, and it's been delightful working with them. But it's about us learning something new as well. On the plus side, I think that some of the children that we might have needed to scope had treatments implemented that we did empirically and got better. So in some ways, we've actually also avoided procedures in some children, hopefully for the better and longer term. I think that we also not scoping and presumably for surgeons not operating, you potentially get de-skilled. I mean, thank goodness we haven't been, but there's the potential that not doing what you do all the time and every day, you lose the flow and you have to sort of get up to speed again. But I'm pleased that wasn't impacted on us, but it was always a theoretical risk. The digital opportunities have been incredible in terms of remote consultations. Patients have welcomed it, actually. They've saved time in traveling to hospitals. Whether they're at school or homeschooled at the moment, they've saved themselves from missing a huge number of lessons. Parents aren't taken out of work. It's probably good for the environment as well. They're not brought into common areas where there's a whole lot of people in waiting areas. So I think there's been quite a lot of positives as well. I think that's probably the biggest challenges in terms of new things happening. Celiac disease has been one of the things which pediatrics has trailblazed over adults, in that we have developed strategies and evidence that not every celiac needs a scope for diagnosis, and you can base diagnosis on certain serology thresholds. So that's been quite helpful.
Explain what celiac disease is.
Yeah, celiac disease is a lifelong condition at the moment, although who knows what developments will come in time, where children and adults are gluten intolerant, and it causes inflammation in the bowel and potentially in other areas of the body, impacting on potentially growth, iron and nutrient absorption, and going gluten-free results in all of those abnormalities returning to normal and returning to good health very quickly and long term. And you usually diagnose that with a biopsy of the duodenum to look for the typical intestinal inflammation and pattern of change, but it isn't always necessary now, and that has meant that a lot of children have not needed to be put through general anesthetics and endoscopies. And I've heard recently that, particularly due to COVID now, adults are examining the same options in the adult population for diagnosing celiac disease without the mandatory endoscopy, which is currently in place.
Thank you. So we're going to open up the discussion to the panel. Please use the chat box in the audience for any questions. There's a Lisa, if you're able to put on the chat line a bit later on the web address that you had highlighted in your talk, that'll be good. Before you do that, though, actually mental health has come up a number of times already, mentioned by Andy, your case that you just mentioned now, Mark. Lisa, in terms of the whole issue of mental health in children, how do you address that?
Okay, so for 20 of my 27 years at Heathfield Medical Centre, I was the mental health lead for both adults and children. And we've seen an explosion in mental health in children and adolescents during the pandemic, ranging from a large rise in eating disorders to anxiety to depression. And it's hard as parents, we're working, and my advice here would be to structure your day. Be involved with your child, make sure you listen to them and take what they say seriously. Quite interesting, I was having a conversation with a teacher friend of mine a couple of months ago, and she said that the most common thing that her children in her class talked to her about before Christmas was the anxiety of being away from their children and away from their teachers, and actually quite scared about the Christmas holidays because they would have little or no social contact. So making sure that your kids are in contact with their friends, but at the same time having family time, screen-free time, exercise time. And again, using the wealth of websites that are available with self-help. So tooth exposure, Jammy. In fact, Jammy has a webinar on Thursday, which I think is probably mainly aimed at adults. Keep in touch with your shul. All the shuls are, I know we're at Kinloss, but all the other shuls are also having programs for young children and people. And BBC Bite Size has got an excellent program for children. And one of the other things I have found is that local libraries are doing song time, story time. So that's where you can your kids can interact with their friends. Again, don't be afraid to reach out. NHS resources are very stretched. But they are there, and there may be a delay, but I would advise using them. And just keep on the lookout for anything out of the ordinary.
Any of the other panelists want to make any comments related to that before we move to the next question?
I mean, I think that accessing mental health, specialist care, has been very difficult, and I've seen and been part of lots of discussions where the teams in CAMS are trying really hard to fit in as much as possible, but I think there's an acute awareness of a real mental health crisis looming in terms of accessing quick mental health for healthcare for children.
Thank you. Moving on, Lee, there's a lot of discussion about nursery schools, children. How infectious are children with coronavirus amongst children and also to adults who might be in the environment? And what's your view on that whole topic?
So, I mean, this is always a difficult question, and I think the government are trying to juggle the correct way to manage this, because, of course, Lisa's already alluded to the importance of social contact between children, trying to have some sense of normality with their friends, with their peers, with their teachers. And on the other hand, there's always a concern that we will, spread COVID further. I think the initial virus, that came across in March, that we had the first lockdown for, was thought to be less contagious to children, perhaps because of the way the virus enters the body. And I think there's more concern about the current new mutation that might allow the virus to infect children more easily. I think the important thing to stress is that despite the change in the possibility of children becoming more infected, I think that they are no more likely to become unwell or to become particularly unwell or very sick with the virus. And the same advice goes forward. Children on the whole, thankfully, have been very much sailing through coronavirus. Yes, there are occasional children who do become more unwell, and it's very important, if your child does have coronavirus or any other illness and you think that they are unwell, that you seek medical attention as soon as possible. But I think on the whole, children have been fighting this virus without too many problems. Whether they should go to school or not, I think comes in terms of spread of infection. I personally feel that if they can go to school, they should go to school. I think schools are safe places. There are lots and lots of ways of trying to limit spread of the virus within school. There's been a lot of effort both by schools and by government in order to try to prevent spread. And I think what's more important to stress is that when parents come and pick their children up from school, that they should maintain social distancing and try to make sure that that's not a way of spreading the virus rather than from the children themselves. So I think spread of virus from children is still deemed to be low risk. We should try to make sure that if it's advised by the government, by NHS England, we should try to make sure that children do go to school if possible, because their education is extremely important, and a huge amount of disruption can have impacts both now and in the future on both education and mental health.
Okay, so Andy, what's your recommendation? A child has a fall and he's got a bit of a swollen ankle or a knee. What's your advice about going to the A&E department? You're mute.
Okay, I think that brings up an interesting question back to what I said before, where people are avoiding going to A&E. When you fall over and you injure yourself, for example, if you sprained or broke your ankle, people often worry whether or not the bones are broken. Probably a good interjection at the opportunity to say that a fracture and a break, people ask me, what's the difference between a fracture and a break? The answer is nothing. They're exactly the same. So a fracture is a break. Hope we've cleared that bit up. But when people go, what they often do is they go to A&E and they get told, I've sprained my ankle, I've broken it, and they get told there's no break, off you go, don't worry about it. And in the pandemic, people weren't even going to A&E. And the problem there is that actually a sprained ankle or severe sprain of an ankle is often worse than a broken bone. And the reason for that is that the ligaments, they get pulled off from the bone or they get torn. And if they don't heal normally, then what can end up happening is you get recurrent injuries, recurrent problems, and problems later on in life. And so it's really important to treat sprained ankles in the emergency setting. And there's simple things that you can do at home. There's something we do, which is called RICE, rest, ice, elevation, and compression. So putting an ice pack onto it and wrapping it in a bandage or putting an ankle brace on is a really good thing to do. And I probably have a very low threshold to recommend that if someone does sprain their ankle now or any time, that they do put on a brace of some sort, because that allows the ligaments to heal in a normal place and they should have then no long-term problems. If they heal stretched or with too much give, then you can have ongoing instability, further sprains, or further problems.
Thank you. Mark, some children present with abdominal pain, diarrhea, well, very commonly present to you with abdominal pain, diarrhea. how is that impacted with COVID-19? And if they have got that, how infectious is it?
So around 25 to 30% of children with COVID can have gastrointestinal effects, either vomiting or diarrhea or abdominal pain, as you say. It's shorter lived than would be for some of the chronic conditions we deal with, such as IBD. So it would depend on severity. I mean, of course, if they've got severe abdominal pain, they would need to get assessed to make sure there's nothing serious going on, such as appendicitis. And I would echo the discussions previously that if parents are concerned about the child, they need to at least discuss it with a health professional and work out if that child needs to be seen acutely or whether any tests or treatment can be implemented. So yes, gastrointestinal effects are common, but they are short-lived. So it'll be for a few days rather than a few weeks. Where COVID is associated, it is more likely to be also associated with a fever. So I think abdominal pain, diarrhea, and vomiting without a fever is less likely to be COVID.
Okay, thank you. Moving on, and really, Lee, and it's probably a question for you more than Lisa. There's in the news now this whole question of multisystem inflammatory syndrome in children, and you have some very anxious parents. But do you want to just give some reassurance in terms of that and how rare it is, and just make a comment on this syndrome?
Okay, thank you, Martyn. I think the important point to stress is it is very rare. And although obviously anything nasty and potentially dangerous is always stressed upon by newspapers and social media, the important point to recognize is what I mentioned before and what other people have mentioned, that COVID-19 in children across the board is a mild disease. We see very, very, very few children who are very unwell with it. Most of the children who do get unwell already have underlying health issues which have been raised, and that's why they were asked to shield. In terms of multi-PIMS or multi-inflammatory disease, it is something which we are seeing occasionally. I think, again, to stress, it is very rare. If you feel that your child is more unwell than they should be, most children with COVID only get a little bit of fever, if that, bit of a runny nose, then you should seek medical help. So talk to your GP, if you're very worried, obviously go to A&E, talk to your paediatrician. I think it's important that people to know that this is a very rare event, and it's something that we are not seeing very much of, albeit there are some cases, but this is not universally a problem. And comparing it to adult medicine, where almost every single patient in hospital at the moment has COVID-19, it's extremely rare.
Thank you. Lisa, just there's concern, I had a question from young mother who was breastfeeding. Can tell two things, actually. Can you pass the virus on through breastfeeding? What's your advice? And also the question of antibodies. If you've had COVID-19 in your breastfeeding, could that be passed on to the baby?
Okay, so there's still very limited evidence on this, and there are trials ongoing. But the general advice is that it is safe to breastfeed, and actually it's more detrimental to the bonding process if you don't breastfeed. As far as antibody passing, I'm afraid I don't know that. That's a bit above me. But you can, the greatest risk for your baby catching COVID is actually the close contact. So look away, wear a mask. But I would reinforce to carry on breastfeeding, and that's what the NCT is saying, and that's what the pediatricians are saying. And
Lee, I think from my reading, there's some evidence that the antibodies pass in breast milk, so it could even be positive from that perspective if a mother has had coronavirus infection.
Yeah, I think so. I mean, the antibodies passed in breast milk are IgA antibodies, not IgG antibodies, but there is some evidence that will also help, and especially prevent gut-related issues that are associated with COVID. So I think breastfeeding, breast milk doesn't just have antibodies in it, also has various other proteins and cell messengers that help the gut and help prevent the baby get infection. So on many levels, besides just the bonding, which is extremely important, it's important to promote breastfeeding for all mothers, especially if you also happen to have an illness, COVID or otherwise.
Thank you. Andy, you said that kids are becoming more deconditioned. What sort of problems would that lead to from in terms of your specialties? You're muted.
If we move to the other end of the spectrum, so to the elderly, we're all worried about people developing osteoporosis and fragility fractures. That means people are having weak bones and breaking them. And what we now know is that as you get older, in fact, it's perhaps not just the weakness of the bones that matter, but also what we call sarcoplasia, or lack of muscle content. And so actually, as you age, muscle is one of the most important things, not just for bone health, but for our physical health as well. And so going back to the beginning, clearly kids have an essential role in getting stronger and getting their muscles as strong as possible. And being overweight and deconditioned is not good for anyone. But one of the biggest problems and challenges that we're seeing at the moment is that a lot of kids are being diagnosed as being stretchy or bendy or hypermobile, as the term is used. And clearly there's a spectrum of people that are very stretchy, and there are also people that are less so stretchy. You often see it as flat feet or bendy knees or bandy knees. And what's more important with these kids is that they also have weak spines, weak control of their pelvis and their limbs, and they have global weakness. And so being deconditioned is clearly the worst thing that can possibly happen to them. And if you want to test your own children, just ask them to stand on tiptoes, take their shoes and socks off, ask them to stand on tiptoes, and ask them then to close their eyes. And what you'll see is they're using their toes to grip the floor, or their knees are shaking, or their heels are shaking. And these are all signs of a weak core. And now we're getting much better at understanding it, and understanding that you've got to address these as a kid, because most of the postural problems that we get and problems that we develop in adulthood started when we were as a child or in our adolescent years. And so it's really important, just like we're all used to doing lifestyle changes when we hit our 30s and 40s, to perhaps try and address them when they're much younger. Now the physios and the OTs at the Wellington and the Portland have all come together, and we're developing very strong programs of activity that allow kids in a multidisciplinary format to get stronger and to make it fun. I think I've got a video here just to show you some of the stuff that you can do nowadays to make it fun for the kids, so you can make it entertaining, so they're not just ask them to touch their toes and stretch their legs, but actually trying to sort of move across balls and a balance, and then they play games with it. And that sort of stuff allows kids to really learn to use a lot of the muscles which they've neglected whilst they're playing Fortnite.
And do you recommend, there's some evidence in adults in terms of vitamin D and so on, supplementation for the bones. Lisa, what do you recommend? Vitamin supplementation?
So the answer to that is a definite yes. You don't want to overdo it, so I'm recommending children's vitamins on a daily basis. And for those in the audience that know me, they know that I don't normally do that. But you've got to have a healthy diet. We're not getting away. There's no sunlight, and there is some, as you say, there is some evidence with vitamin D.
And Mark, you've got young children on immunosuppression because of their Crohn's disease and ulcerative colitis, so they might be on steroids or azathioprine or infliximab. And what do you advise in this situation with the COVID-19 about continuing with treatment, the risks, and how do you take those concerns forward?
We keep monitoring all publications and releases that come out of different groups, the British Society of Paediatric Gastroenterology, or the BSG, British Society of Gastroenterology. we monitor government guidelines as well regarding immunosuppression and shielding. It seems to some extent that patients with IBD on immunosuppression treatment are no worse off, possibly even somewhat protected from the immune cascade and effects that are related to COVID. So the only caution, I suppose, is those that are acutely unwell with very active disease, or those that have been on steroids recently or on steroid doses of 20 milligrams or higher. They would need to then form a shielding policy according to the government guidelines, and they would be regarded in the highest risk. But generally, those that are stable on the immunosuppression treatment would only be regarded as intermittent risk and would continue most of their general daily activities without a problem.
Lee, is there ever a situation where children should be vaccinated?
It's a hot topic. I think they're so far at the moment, vaccines are not licensed in anyone under the age of 16 years. I believe there are some studies going on at the moment looking at children from the age of 12, but we stretch all the way to 18. So I think definitely for children who've got respiratory disorders, some patients are on long-term ventilation. When they should definitely be considered for early vaccination. Hopefully, the more people that are vaccinated, the sooner the better.
Okay, very good. I think we've run over time. Actually, we were due to finish just a couple of minutes ago. So I want to thank you all for your participation this evening. We've covered many broad issues related to pediatrics and COVID-19, and so really appreciate your expertise and time tonight. So thank you very much. And to the audience, if you'll be receiving a feedback form as well, so if you'd like to just complete that, then that would be good. And there will be the second in the series will be on the 2nd of March, which is the latest thinking on disease and medical advances in the adult population with Clive Bonney, Hugh Bainan, Daniel Hochhauser, Jenny Cross, and I'll be chairing that meeting. So once again, thank you very much to our expert panel and to you, the audience, and I wish you a good night and stay safe and well. All the best to you.
Bye-bye. Thank you.